Good day, everyone. My name is Kelly Cox, and I'm with the International Myeloma Foundation here in Los Angeles. You are attending a regional community workshop. I want to thank you personally for doing this on a Saturday. We all know you have, well, I had chores and so forth to do. I guess my wife will have me do them later, but that's okay. That's what we're all about, is helping people. I want to say that this program has been going on for 15 years, and this is our 110th workshop. They are very successful because of our informal formality. I'd like to thank our sponsors. That will be Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, Takeda, and Takeda. Their generous sponsorship has been great for us. Now, as we follow the workshop, I want to tell you, if you'll be getting an email that says, here's the slides and the video replay. So if you haven't got it all on your legal pad with your number 2 pencil, you can come back and visit it. Now, on your screen, you'll see a thing that says that we want to hear from you. And there's a little clipboard that is for feedback. This is incredibly important. If you guys want, if the attendees want us to bring it back to your area, you have to fill this out so we know that what we're doing is good for you. So please do so. Oh, today is a great day. Saturday, August 28th. I know some of you are looking at this date and saying, next week is September. Can you guys believe next week's September? I can't. But let's go with this. I'm Kelly Cox. I told you a little bit about me. It's 10 o'clock right now. 10:05, we'll listen to a dear friend, Joseph Mikhael, who's going to talk about myeloma 101 and frontline therapy. We'll have some questions and answering. They'll moderate that. Then we're going to do a little bit of a stretch break, give you in between times. And then we'll come out to another dear friend of mine, Rafat Abanar, who's going to talk about relapse therapy and clinical trials. I can't believe all the people I have on this one. And Tiffany Richards, who I've worked with for many years, has a lot of acronyms after her name and works at MD Anderson Cancer Center. And she's going to talk about how to manage myeloma symptoms and side effects. All 3 very important talks while you're on your journey with myeloma. So with all that being said, I'd like to introduce Dr. Mikhael. He is the Chief Medical Officer of the IMF, and he's going to talk about some great things that you need to know and that will help you. Even if you've had myeloma for a period of time, I always find Myeloma 101 has items in the slide deck that will help you out. And of course, frontline therapy is what it is. Dr. Mikhael, you take it away from here.
Great. Thanks so much, Kelly. It's always a joy to be with you, of course, my friend. And as always, you look stellar, and particularly to share the stage virtually with 2 very dear friends, Tiffany and Rafat. Please don't hold it against them that they're good friends of mine, but I just love them both. They are so committed to their patients, even on a Saturday morning. Obviously, they want to spend time helping us through this. So, Kelly mentioned it already. I think it's really important actually to always get a refresher on this disease. You may be, even as Kelly mentioned, a very expert, as it were, in myeloma, or maybe you're here today and this is the first workshop you've been to out of the 110 that Kelly has been at. And so we want to just really review quickly the basics of blood and cancer and how this fits into multiple myeloma. What are its key features? And then I'll focus a bit my talk on how we initially treat multiple myeloma and the role of stem cell transplants. And as you heard later, Rafat will cover a little bit more of, unfortunately, when the disease does come back. So again, really getting simple. This may seem uber simple to some of you, but what is the blood? Well, the blood is an organ. We as hematologists are a bit biased. We think the coolest organ in the body, but it's made up of 2 things. There's the liquid part of it, and then there's the sort of solid part of it, as it were. And the liquid part we call plasma, and the solid part of it are really the cells that are within that blood. And I always like to I know it's a little bit early, especially for Kelly and I here on the West Coast, but I think of it as wine. We have red wine, white wine, and rosé wine. And Kelly, I know, occasionally enjoys a glass of wine. And so similarly, we have red cells, white cells, and rosé or platelet cells. Red cells are like just little red trucks, basically, that carry oxygen. When you breathe in, they pick up the oxygen, and then they go deliver them to the tissues, come back for more. White cells, which we're going to focus on in a few minutes, are like our immune system. They're like the army, or in fact the whole of the military. We have 5 kinds of white cells and 5 major branches of the military, as it were. And then lastly, platelets are tiny little cells that help you clot. I call them the ambulance because they're the first ones on the scene. If you cut yourself, they're the ones that get there first and plug up the hole. And the factory of these cells is the bone marrow. And that's where we're going to direct our attention in a moment, because that's where all these cells are produced. Now, on the other hand, what is cancer? Well, cancer by definition really is identical uncontrolled growth. It's just easier to capture this in your mind if you think of a piece of breast tissue or lung tissue or colon tissue. But it's the same principle when we deal with blood cancers. It's just coming out of the bone marrow, that those cells that are in the bone marrow are growing out of control. And there's all sorts of different kinds of cells in that factory of the blood that we'll talk about in a moment. The challenging bit here is those very same cells are the ones that are supposed to help you. So it would be like the military is meant to protect you, but now unfortunately it's reversed itself against you, friendly fire as it were. And that's what happens with blood cancers in general. Well, myeloma is a cancer that we think of as a blood cancer, but originates in the bone marrow. So in that factory of your blood, there are some very specific cells called plasma cells. Now, you may not know this, but we've been talking about plasma cells for the last 2 years with all, sadly, that's been happening with COVID. Anytime you refer to an antibody, we're actually referring to plasma cells, because those are the cells that make the antibodies. When you get a vaccine, and we're going to strongly encourage everyone to get the COVID vaccine, let alone the flu shot and measles, mumps, rubella, when you get any of these vaccines, they send a message to your plasma cells, and those plasma cells make antibodies that get stored to protect you in case you get infected. Well, now that same machinery that does good things, that makes good antibodies, unfortunately becomes cancerous in myeloma. And so those same cells, instead of making good antibodies, like you can see in the picture here, they make, if you will, abnormal antibodies or bad antibodies, or sometimes we call them M or monoclonal, because they're mono, they're all the same size and shape, as opposed to polyclonal, which is good. When you get, as I say, vaccines and exposed to different things, you make all sorts of different types of antibodies. But now we're making this monoclonal antibody, which is very bad. And sadly, those antibodies can go and attack the kidney. They can attack the bone, and they mess with the whole hormonal system of one's body. Now, what about myeloma? We expect, unfortunately, to make about 35,000 diagnoses of myeloma in the country this year, and sadly, a little over 12,000 people are estimated to die of this disease. Although this has really been improving, especially in the last 10 years. Rafat and I have been around long enough to sadly remember the days when the average survival of myeloma was 1 or 2 years. Now it's pushing a decade. A couple of important things, though, is that myeloma is twice as common in the African American population than it is in the Caucasian population. And perhaps even more striking and sadly, we see that the survival of African American patients historically has been about half of that of white patients. And a lot of that has to do with access to therapies and a whole series of things that we're addressing at the IMF in the Empower project. If you want to learn more about this, then go to our IMF website, and you can see on our diversity page and our Empower page what we're doing to empower patients and communities to change the course of myeloma, to reverse this awful trend where patients, Hispanic patients and African American patients, have inferior outcomes to white patients. But nonetheless, overall, we are making tremendous progress in this disease. And I'm always excited to listen to Rafat, well, no matter what Rafat's talking about, but particular when Rafat talks about some of these new drugs that are coming, because these are very much influencing what we do. So in summary, myeloma is a cancer of the plasma cell. It accounts for about 2% of all cancers. On average, the diagnosis age is around 69, but it's significantly younger, interestingly, in African Americans and Hispanic Americans, about 4 or 5 years younger. And we can classify, and I'm not going to get into too much detail here, but we can classify the type of myeloma based on the type of antibody that's produced. So typically, we make about 5 different antibodies, what's called, we love in medicine to use words that patients don't understand. Our word for antibody is immunoglobulin. And so we have immunoglobulin or antibody type G, A, M, D, and E. Most patients have IgG myeloma or immunoglobulin G myeloma, but some have A and some have M, rarely D and E. Lastly, these monoclonal proteins, these immunoglobulins that we make, that we've been talking about, they kind of look like this funny shaped Y thing, and they're composed of 2 bits. There's the big long bits and those little bits on the side. The big bits are called heavy chains. The little bits are called light chains. And in fact, 20% of myeloma patients only have the light chains. So some of the typical testing that we do is not easily detected for these patients. And so we have to, as we're going to show you when we do testing, we look at both the heavy chain and the light chain as we go through. The other thing to remember about myeloma is it's part of a spectrum. Remember I said myeloma is a little less than 2% of all cancers? That's true, but in fact, believe it or not, nearly 5% of the whole population over the age of 30 or 40 actually have a monoclonal protein, actually have an abnormal protein. Now, they don't have myeloma because they make just this tiny little schmutz of protein, this tiny little bit that's never going to hurt them, or at least is not hurting them now. And we call that condition MGUS, or monoclonal gammopathy of undetermined significance. I know that's a mouthful, but that was a phrase coined by Dr. Bob Kyle from Mayo Clinic, who I had the privilege of working with for many years, who saw that this little abnormal protein was in the blood of a lot of patients, but it didn't actually hurt them. There's a category up from that called smoldering myeloma, where people actually do have myeloma by virtue of those bad plasma cells in the bone marrow, but they don't have enough of that bad protein to actually hurt their bodies. And then, of course, there's true active myeloma, and that's a whole other topic in and of itself. But to have active myeloma, you have to have those plasma cells in your bone marrow quantified as greater than 10% and have what we call a myeloma-defining event, or an MDE. And it's one of these 7 things that are called the CRAB criteria, and then we added 3 more. I'll show you in a moment how I call it SLIM CRAB, my huge contribution to the myeloma community. I came up with the SLIM CRAB acronym, and that's it. I can retire now. So CRAB stands for calcium being up. R stands for renal or kidney problems. A stands for anemia or a low red blood cell count. And B stands for bone disease, or sometimes when people have either bone fractures or thinning of the bone. Furthermore, a few years ago, we added 3 criteria that if someone has more than 60% plasma cells, if their light chains are so high that the ones that are involved are higher than the ones that are not involved by 100-fold, we think that's significant. And if someone has had an MRI of their bone marrow and it looks like they have more than one what we call focal lesion, then we consider them to have true myeloma. So another way of defining this, as I mentioned, is that we call this SLIM CRAB. So people have to have this to have true active myeloma. Otherwise, they may be classified as smoldering myeloma. Now, I won't get into a lot of detail, but unfortunately, these aren't just numbers on a page. This really affects patients. And so people who have low blood counts can be really tired. When the bone damage can cause an inordinate amount of pain. People can have infections. There are a lot of things, sadly, associated with these CRAB symptoms. Now, the other last point I want to make really about diagnosis is that this is a tricky diagnosis to make. It's not easily made. Although we do have some fancy tests that can help us, we know that that it is not always easy to make. And so, as you can see, the majority of people have a low blood count, and many people have back pain, and some have very significant fatigue, but these are not specific to multiple myeloma, and so often the diagnosis is delayed. I mentioned earlier that this disease is different within the African American community, and I often talk about these key facts that I like to share with people, which is that there's a longer time from the initiation of symptoms and to diagnosis in African Americans. Now, in fact, all myeloma patients, unfortunately, have some kind of delay, but it's particularly prolonged in African American patients. I mentioned already that they're younger at diagnosis by about 5 years, that the disease is twice as common. And you're going to hear today from myself and Rafat in particular, and from Tiffany as well, as we talk about all of these different modalities of treatment, that the 3 T's are really important in myeloma: triplets, transplants, and trials. And sadly, we know that access to those 3 are reduced within the African American population, which has led, unfortunately, to reduced survival, as we've mentioned. For all these great advances, for every 1.3 years of life gained in the white population, we've only seen 0.8 in blacks. However, we do have encouraging data that when given the same therapy, African American patients actually can do as well, if not better. So as we come through the diagnosis of myeloma, there are all sorts of tests, and time would prevent me from going through all of these in detail. But I saw that my friend Steve from Florida had a great question around involved and uninvolved light chains. But we can look through all the different kinds of features here that people can have their blood tests. When you have myeloma, you have a certain kind of myeloma, as I mentioned, that IgA or IgG or IgD or E. And then there's a subset within that of what we call the light chains. And there are 2 types of light chains: kappa chains and lambda chains. And one of those 2 predominate in any one patient's diagnosis. Because remember, I mentioned cancer is identical, and so it is one of those forms. So people have either kappa or lambda. So when we measure that slim crab criteria, we can look how much kappa does someone have and how much lambda does someone have. And the one that predominates, is it 100 times higher than the one that is not predominant? And that is one of the features of multiple myeloma. When you think of cancer, you think of how important it is to stage patients. Myeloma is a little bit different that way, to be blunt. We do have 3 stages, and you can see the staging system here based on some blood tests and some key chromosomal or tests that we do on the cancer cells, not your own cells per se, but we can test those plasma cells in your bone marrow and look at their genes and see if they're expressing certain things or not expressing certain things, or if there's some chromosomal changes. And that can help us determine how aggressive the multiple myeloma is. And we'll be talking a bit more about this later, because we sometimes differentiate people from high risk and standard risk myeloma based on this. So we do have a different staging system, but it's not quite as dramatic as, let's say, some solid tumors where there's just such a vast difference between stage 1 and stage 4. In those cases, here we only have 3 stages as described. So as we start to now think about treatment and how we use frontline treatment, so I've been given 30 minutes to do this, and we've spent about 15 minutes now talking about what myeloma is about. Now we're going to dive into treatment. One of the things that I'm going to say over and over again that is so important is we want you, and even just by being a participant in this workshop today, you are demonstrating that you want to be involved in your care. And that's really important. The days of, the doctor or the nurse practitioner coming in and saying, or the physician assistant saying, this is what you're going to get, you'll take it and you'll like it, are gone. We want to participate with you. And so when we choose a treatment plan, there's lots of features that go into it. We don't have a simple cookbook in myeloma where we give everybody this and then everybody this and then everybody that. It really depends on so many different things: what your goals are, how old you are, what other medical conditions you might have, what symptoms you've been experiencing, where you live. All of these things will influence. Now, you're going to be hearing about a lot of these drugs. I'm not going to go through them all, but we record this for you and have the slides for you, of course, so you can use it as a reference. But we have all these major different classes of drugs together that include what are called the immunomodulatory drugs, the proteasome inhibitors, other forms of chemotherapy, steroids, monoclonal antibodies, and others that we're going to show to you as we go through. And so we will be making references to these. And there are more, as you're going to see, so many more. One of the things we encourage is that you can have a second, or what I prefer to call an expert opinion in this, because this is a complicated disease, and many of us, like Rafat and Tiffany and myself, focus in this area and can often provide extra help specifically to you. So when we start to think about treatment, I'm going to skip over that complicated slide I have about the picture of the bone marrow just to dive right into treatment. Here are what I call 6 important principles. So if you've been napping or you need another cup of coffee, Kelly, this is the time to wake up for a few seconds and listen, because the types of treatments constantly change, but the principles are relatively similar. 1, the frontline therapy, the first thing we treat you with, has an impact on your long-term survival. So we don't want to skimp up front. We don't so-called save the best for last. We try to use our best therapies early on in frontline therapy, and as Rafat will share with you, in early relapse. As I often say, saving the best for last is great for a Hallmark movie, but not for multiple myeloma, right? We want to use what we have early on. Number 3, we leverage combinations of drugs. You'll find that there's no one magic pill in myeloma. It's a combination. Fourthly, we seek what we call a deep and a durable remission. So we're going to talk to you about how much that monoclonal protein is reduced and then how long it stays there. So we don't just want a deep response, we want a durable one. And we mix and match right now from 3 major classes where we typically add steroids or dexamethasone to it, those 3 classes that I've shared with you already. And then we decide early on who is and who's not going to go to stem cell transplant. And based on transplant eligibility, we have kind of 2 pathways for frontline therapy with different options. And then Rafat will share with you later what we do at relapse, where there are even more combinations and more complexity to it. So in the last 12 minutes that I have with you, let's think about how we approach patients who are going to transplant and patients who are not going to transplant. And what I've tried to do at each of these regional community workshops is bring a few questions that are really relevant to helping understand why we treat the way we do. So my 3 questions are, is transplant still necessary? What is the best triplet combination to use? And should we now be going to quadruplets? Well, should we still use transplant? Well, we've had 2 really important studies in this realm. One is the IFM study, where patients were either given RVD, so Revlimid, Velcade, and Dex alone, or RVD plus transplant. And the way these curves work is the higher up you are on the curve, the more horizontal it is, the better. We saw that if you had a transplant, you stayed in remission for about a year longer than you didn't. So this was still a strong endorsement for continuing transplant. Now, interestingly, it didn't affect people's what we call overall survival, mostly because about 80% of people in the non-transplant arm got one later. But nonetheless, we know that transplant has a benefit. And so now we're looking at other studies with different combinations. That was with VRD, but sometimes we can use what's called KRD, or carfilzomib, lenalidomide, and dexamethasone for the same purpose. And so this very large Italian study, which looks very complicated, but again, I'll simplify it, where patients were either given a whole year of KRD versus just 8 months of KRD plus a transplant. And similarly, interestingly here, when you got a transplant, it initially didn't look like, if you look at those second 2 sets of bars, now it's called that VGPR, or a 90% reduction or very good partial remission, it looked pretty similar. 89% if you had a transplant, 87% if you didn't have a transplant. However, going back to our curves, if you look at the one on the left, in blue, those are the people that had the transplant. So it still looks, even with a whole year of that kind of treatment, having a transplant made it a little bit better. I won't go into the second curve there, which talks about maintenance therapy today, but we could leave it for Q&A, that there actually looks like there may be a benefit of adding more than just Revlimid to maintenance therapy, which is typically what we do. But lastly, we are now looking at 4 drug combinations, where if we thought that RVD and transplant's better than RVD, what if we added daratumumab to the RVD? And it's a little bit early to make this conclusion, but from what we can see now, if you look at the way these bars are built, the more purple, the better. Think of it that way. And so it looks like the DRVD arm is getting deeper responses. Remember we talked about deep and durable? It looks like we can maybe get a deeper response when we go to 4 drugs, although that question is still being pursued because it's a little too early to say by these curves if the 4 drugs keeps you in remission longer. It seems to get more people deep into remission, but whether or not it stays there is something we need a little bit more time to determine. And then lastly, in the 4 drug combinations, now we're also looking, just like we looked from VRD and KRD, now we're looking at DARA-VRD and DARA-KRD in different kinds of studies to see if that could be the best 4 drug combination. Any way you look at it, we are seeing response rates that frankly we've never seen before. If I told Rafat 5 years ago, I'm going to be presenting with him at a regional community workshop, and we're going to be talking about people getting into 90% response, or VGPR, very good partial remission, where I may be able to get 90 or 100% of people into response, he would have thought I was maybe losing it. It's remarkable how much better we're getting with these upfront therapies. So to conclude the transplant eligible group, is transplant still necessary? Yes, it seems that it still does contribute to both the depth and the duration of response. Question number 2, what is the best triplet combination? Is it VRD or KRD? And in these transplant eligible patients, they both seem to be very legitimate, and you and your doctor may decide to choose one or the other based on some of your own features and what you may, the kind of myeloma that you may have. And then thirdly, should we switch to quadruplets? Are we going now to DARA-VRD or DARA-KRD, or sometimes another drug much like daratumumab, isatuximab VRD or isatuximab KRD? I think it's still a little bit early to make a tidal shift, but I think by the time Kelly, we do our next regional community workshop in this area, we may have more answers around this, and we may indeed be using quadruplets. So before I close, in my last 6 or 7 minutes, let's talk about transplant ineligible. Now, I didn't get into a lot of detail as how we choose versus who's eligible or who's not. One key thing is it's not based on age alone, but generally speaking, in patients who are 70 years and older, we're very careful whom we might select to take to stem cell transplants, because we know that transplant can be a bit tough on the system, especially maybe if someone has heart disease or kidney disease or lung disease. We may not do that. But I don't want you to feel that it's sort of transplant or bust. You know, it's not like if you don't get a transplant, you don't do well. If anything, I'm going to show you in a moment, we have some extraordinary trials, clinical trials that have shown to us how well patients can do with never seeing a transplant. And so again, I come with 3 questions. Are triplets better than doublets? How long should patients be treated? And how can we make these combinations more tolerable? Well, one of the key studies that did show that triplets are better than doublets was led by our boss, Dr. Brian Dury, who I'm sure you all know. We still classify myeloma after his name, the Salmon Dury classification. He led this SWOG study that compared VRD to just RD, or bortezomib, lenalidomide, dexamethasone, versus lenalidomide, dexamethasone. And we saw unequivocally that there was quite a dramatic improvement in what we call progression-free survival, or the time in remission was about a year longer if you had the triplet combination. And it didn't just, as you can see there, it didn't just influence what we call progression-free survival, it affected overall survival. So people in remission and stayed alive significantly longer with this combination. And so this is one of the reasons why VRD has really become the standard of care. Now, we give the Velcade or the bortezomib a little bit differently than maybe it was done in the SWOG study. I'd be interested to know later what Tiffany thinks about this, because she's the master of using drugs correctly to minimize the toxicity to a patient. But I can say when I use bortezomib in this population, I always use it subcutaneously. I always use it weekly. And actually, after the first 6 months, I try to go to every other week to keep them on bortezomib for longer, but to reduce the risk of neuropathy or nerve damage. There's another study that looked at comparing these 2 regimens that we talked about earlier, VRD and KRD, in transplant ineligible patients. And there really wasn't a significant difference in the outcomes. There was a bit of a difference in the toxicities, and so we are careful when we use KRD in that population. But again, if you've been napping, this is where I want you to wake up for a couple of minutes, because This is the most recent data that was just presented at our European meeting in June, where another combination using daratumumab plus lenalidomide and dexamethasone versus lenalidomide and dexamethasone was presented. So a similar design to the SWOG study that Dr. Dury led, but here both drugs of daratumumab and lenalidomide are given indefinitely, as opposed to just given for the first 6 months like in the VRD study. And we have some of the most impressive results we've ever seen in myeloma, where at 60 months, I mean, we're talking like 5 years, over half of patients are still in remission. And most importantly, at 5 years, over 2/3 of patients are still alive. This is something that we would not have seen with any other regimen up until now. So to answer these 3 questions, are triplets better than doublets? Yes, this has been a consistent trend, but we have to match it to the patient. There are still some patients who may benefit from a doublet because it may be too hard for them to get 3 drugs together. Question number 2, how long should patients be treated? Well, in general, the longer the better. Now, I don't want to make it sound, again, like you'll take it and you'll like it and you'll ask for more. You know, it's not like we're going to treat everybody forever. But that combination of daratumumab and lenalidomide together definitely kept people in remission for longer. Hopefully, we are, as we look at things like MRD testing or minimal residual disease testing, we are going to have so-called stopping rules. So there may be times where we can give people drug holidays. And then lastly, how can we make these combinations more tolerable? It's really important that we don't just treat myeloma, we treat people. And this is why Tiffany's lecture today is so utterly important as we come to appreciate how we do this with different drugs, in particular when it comes to dexamethasone, for example, the drug that we all love and hate because we have definitely been using almost too much dexamethasone. I always call them the booster rockets. You know, Tiffany, you've probably heard me use this analogy before. I call them the booster rockets. They're really helpful for the first few months, but then we have to drop the dose of dexamethasone because of the impact on the patient. So to conclude this so that we can wrap up and go into our Q&A, there's really more overlap than ever between transplant eligible and ineligible. We're using very similar combinations. Typically in the transplant ineligible population, I'm choosing 2 out of these 3 drugs. So I'm either giving a DRD or a VRD-like regimen. I tend to favor DRD in general, but I still think for some high-risk patients, I may favor VRD because we know that that may be important for them. So to conclude, another way for the visual learners in the crowd is that we have 4 big pillars of myeloma treatment: proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies, and alkylators, the drug that we typically use for transplant. You're going to hear from Rafat that we've added 3 new pillars, selinexor, belantamab mafodotin, and CAR T-cell therapy, and in the near future, we may add bispecifics. So I showed this before, so looking to the future, things are going to change, and more, even the frontline therapy, as I've said, I think is going to change with more quadruplets. And again, another way of visually looking at this is that we have more combinations than ever. I mean, Kelly, can you have imagined a few years ago that we would have this laundry list of choices that we never had before? And more choice is always better for our patients at the end of the day. It's just a privilege to be a part of the IMF. I absolutely love my job. I have the best job on the planet, and I'm so thankful for it, and to work with people all around the world to take down this disease. So at this point, I am going to stop. And Kelly, I know that some questions are already coming into the Q&A box, but I'll turn it over to you as we start to look at these questions.
Yeah, that was a great presentation. I want to tell you guys, you got to type here, click, and some of you are submitting your questions already. If you don't have any questions, do the review, which is on the clipboard. Let's handle some questions. Joe, you want to take, what's the first one?
Sure, absolutely. So I'll just encourage both Tiffany and Rafat to unmute themselves, because I'm sure I'll direct some of these together. So a few great questions. Please explain the difference between the plasma cell in the marrow and the liquid part of the blood plasma. Thanks, Don. Great question. Sadly, it's just a function of the same word. They're totally separate. So the liquid plasma is different than a plasma cell. It just happens to be in the English language. We've used those two words. So the liquid in your blood is not at all, if you will, connected to the plasma cells. Steve asked about the light chains, and I think we answered that a little bit earlier. And so I will move on to the next question. Someone says, unfortunately, they're confused. Okay, let's try and help you figure this out. I was diagnosed in September 2020 and did not know about my chromosome 1114. I have been in remission for 2 months. How bad are my chromosomes? What kind of maintenance drug should I be on? Is my myeloma aggressive, MRD negative, light chain myeloma? Well, first of all, let me say I'm so glad you're in remission, and I'm so glad you're MRD negative. I didn't spend a lot of time, and perhaps I could have spent more time talking about high risk versus standard risk, but let me take this real quickly. That about 25% of patients have what we call high-risk myeloma, and it's mostly guided by the genetics of what we see in their plasma cells. Sometimes there are other blood tests, as I showed you, with the beta-2 microglobulin, with the albumin, and indeed with the what's called LDH. These are blood markers that the myeloma is very active or growing. Some of these abnormalities that we see in the genes, unfortunately, tell us that someone has high-risk myeloma, mostly something called deletion 17p, or the p53 deletion, which is a gene on chromosome 17. Now, all your chromosomes have a p part and a q part. That's where you get the expression, mind your p's and q's. And so this lives on the p part of chromosome 17. And then there are other ones that are high risk. Interestingly, in the question here, what we call translocation 1114, that means a little piece of 11 and a piece of 14 get together. They're not normally together, and they join forces. That actually overall has portended a good prognosis for patients. That if patients are treated with a proteasome inhibitor and an immunomodulatory drug, they will do, generally speaking, very well. And they may have the opportunity to use a new drug called venetoclax, which is particularly active. So obviously, it's hard to make very specific comments about your case and what maintenance therapy you should be on. Generally speaking, lenalidomide maintenance is the standard of care, but that can be discussed a little bit more offline. Rafat, can I ask you this question? The question came in, are there any biomarkers that can predict who will and who will not benefit from melphalan?
It's a good question. I don't think we know the answer to that. I think if melphalan used in the setting of stem cell transplant, high-dose chemotherapy is really one of the most active drug we have, even in patients who have relapsed, and we use it, as a, salvage treatment, has worked. So to my knowledge, I don't know if we know of a good marker that will tell me if this patient is going to respond or not. Maybe you know better the answer.
No, that's I think the right answer is that right now, as far as we know, until maybe we learn more with time, but right now it seems if someone is eligible that they're going to benefit from a transplant. Tiffany, here's a great question I wouldn't mind asking you if you're okay with it. Is there greater cardiac risk using Kyprolis or carfilzomib if the patient does not have any existing cardiac issues?
Yeah, that's a great question. Generally, what we obtain an echocardiogram prior to starting carfilzomib, just because there was about 5% of patients who had reduced how well the heart pumps in the carfilzomib studies. But generally speaking, most patients do well. We get the echo, and then we'll repeat it if a patient starts to have any symptoms of like lower extremity swelling or shortness of breath, and repeat the echo to see if how well their heart function has reduced, so that we at least have a baseline to compare that to. But there is a little bit more of a cardiac risk using carfilzomib, but most patients are able to tolerate it well and do really well with it.
Great. Thanks, Tiffany. I completely agree. I mean, I think sometimes we can overstate the risk, but we don't want to ever understate it either. Generally speaking, my approach is much like yours, that the two groups of people that we need to make sure we can be careful moving into using carfilzomib. If someone has uncontrolled high blood pressure or uncontrolled heart failure, I want to control it a bit better before I introduce the drug. But I don't disqualify anybody from the drug just because they have a history of heart disease. You know, that we want to treat their myeloma the best way possible. So thank you for your answer. Jack, who is an expert himself in myeloma, asks a question. In Maya, RD also has an impressive progression-free survival. Isn't that result much better than when RD was first tested? You know, it's a great question, Jack, and there's different ways that I can answer it, but let me try and answer it this way, is that every single drug in myeloma has gone through an evolution. It's kind of like, maybe it's not a great analogy, but when cars are first introduced, right, it takes us a while to get a new model car comes in. It takes us a while to get used to it, and with time we optimize it and use it a little bit better. You know, when I think over the history of bortezomib, we've gone from IV twice weekly to subcutaneously once weekly. Carfilzomib, that Tiffany was just telling us about, we've gone from twice weekly to once weekly. Selinexor, we've gone from twice weekly to once weekly. Lenalidomide, here in this case, which I think influences your question, is I think we've become a little bit better at understanding its dosing, and that not everybody needs to start at 25 milligrams because there can be some challenges with that. And so we have, I think, gotten better at managing it. And sometimes I know in a lot of my transplant ineligible patients, I'll use a lower dose of lenalidomide to start, 15 milligrams, 10, and occasionally sometimes 5 milligrams. And I think you hit a bit more of that sweet spot. And that's a really important message today, is that every patient has to be looked at differently. And we want to find that sweet spot where we give the best therapy for the quantity of life to match the quality of life. And thanks, Steve, for pointing out a typo on one of my slides. It is quality of life, not just quality of life, but quality of life. And that is a really important, as Tiffany's going to share with us shortly, that's why it's so important to have strong communication with your healthcare team, because that is what's going to tease out the difference between what's the right dose. Because sometimes people come to these lectures and they hear, oh, lenalidomide maintenance is really good for me, I better take it. And there they are suffering with diarrhea or cramping or infections, when we can adjust the dose to be able to overcome that. All right, lots more questions, so I'll speed it up here. That person who asked about translocation 1114, that is not considered a high-risk abnormality, just to be clear. Rafat, maybe I can ask you this. Can you change from being a high-risk patient, or are you always a high-risk patient?
Sorry.
You're a man in demand, my friend.
I know. I'm sorry about that. So, I mean, I think technically we have always, when, we decide, I'm so sorry about that. Okay. So technically we have, oh my goodness.
You are so popular, man.
I am so sorry. I'm so sorry.
No worries.
I'm going to turn my phone off in a second. You can answer it because you know the answer better than me. But always, I think, once you have that clone, unless you to completely eradicate it, unless you really get rid of it, I think you still have that ugly myeloma clone that may come back as a, if you have, stayed around after the induction treatment, this clone will, become aggressive and mutate. I'm going to talk about that in a minute. So, yeah, I mean, hopefully with all the treatment that available, and you heard from that, Joe, that we are getting amazing deeper results. We're getting more patients with minimal residual disease. So I think we will hopefully get rid of, the high risk disease. I mean, that's the most important thing. I think every one of us is not really settled until we say there's no longer something called high risk smoldering, and the way we do it by combination therapy upfront. And you saw that maybe the 4 drugs and maybe some of the newer drugs that we are testing in the relapse setting become part of the induction treatment, so we can get rid of the high-risk disease. Yeah.
Absolutely. And I think when we look, I mentioned that 25% of people that are diagnosed with high-risk disease, that's pretty much a diagnosis. Unfortunately, that number does grow with time, because over time, you can go from standard risk to high risk. But unfortunately, once someone is, if you will, given that high risk designation, it doesn't mean that we can't treat them. It doesn't mean death is imminent by any means, but it does mean we have to be a little bit more careful because the disease has a greater preponderance to come back. Sometimes I say to patients, high risk disease is like there's more horsepower to the engine of your myeloma. So it has a greater chance to grow back more quickly. And so it's important for us to be really consistently covering it. Here's another great question that someone says, how do you define deep or remission? Again, I didn't go this a lot of detail, so here's a good chance to just take a minute on this because I think it's important. You know, if we're looking at, let's say, I don't know, a lung cancer, the radiologist or the lung cancer doctor will take a ruler, essentially, whether it's on the x-ray or on the person, and say, look, here was your tumor. It was 10 centimeters long. As we treat it, it gets smaller and smaller, and we shrink it down. Well, that's kind of what we do with myeloma. The problem is we don't have a single tumor. We have really, I don't know, again, I'm sorry for all the analogies, but I sometimes say to my patients, myeloma is like a crime scene. You can't look at one piece of evidence. We look at lots of pieces of evidence. The M protein, or that monoclonal spike or protein, the light chain, sometimes imaging helps us as well. But nonetheless, once we've determined what we're going to follow, we have a grading system that if we cut it in half, we call that a partial response. If we cut it by 90%, so from 10 down to 1, for example, that would be a very good partial response. And then if we actually get all the way down to 0, not that it's necessarily a cure, but if we 100% drop, we call that a complete response. We have a few other riders within that, but that's typically how we define it. And so what we have learned is that getting at least a 90% drop is very helpful with respect to people doing better in the long term, because depth, generally speaking, correlates to duration, with maybe the exception, as I commented earlier, of high-risk myeloma, where unfortunately people can get a really deep response, but they relapse more quickly. Now, I understand that we are kind of running out of time for Q&A. I see that some of the Q&As, thank you for whoever said they like my analogies, some of the questions are more related to relapse disease. So, Rafat, I've got a couple of questions here that I'll come back to you on when we compare, let's say, ide-cel and cilta-cel. And we'll talk also a little bit about dosing of lenalidomide at that time. But Kelly, I'm happy to say that we are still on schedule. So I will turn it back to you to, I think, facilitate our little break.
Well, gosh, that was a great talk. I have to go get some crime scene chalk, though. I'm going to figure that out. That's a new analogy. Hopefully it's not my wife putting the chalk around my body, but we'll let it go at that. Thank you, Rafat. That was fantastic. All right, we're going to do a little break here for 10 minutes. Get up, get some coffee, stretch, don't break anything, and come back and we'll see you in 10. Thanks. Okay, I hope everyone's doing all right. I just drank a cup of coffee that burned the roof of my mouth. I should have probably put some ice in it. So I'm really awake right now, and I hope you are too. What a great talk, the first one with Dr. Mikhael. I really appreciate his I do appreciate your analogies and how you put things. I always have. The next talk, another dear friend of mine, Dr. Rafat Abanar from Indiana University School of Medicine, Indianapolis, Indiana. And he's going to talk about relapse therapy and clinical trials. And I know we got a lot of questions coming up. We'll handle those questions when we get done with Rafat. And Rafat, take it away.
Well, good morning, and thanks for inviting me. It's an amazing to see the master give 101 on myeloma. What an incredible talk. Hopefully I can sound a little smart like him, and we'll see what happens. So when should we treat relapse disease? I think that's always the big question. Do we treat at biochemical relapse, or do we treat when they have symptoms related to the disease? So what is biochemical relapse? Somebody who has a myeloma protein that was 0, now it's coming back. Somebody who has an involved light chain that was normal and now it's going up. Do we treat at that time, or do we treat them when they have anemia or hypercalcemia, high calcium, or bone disease, or now they're developing these tumors outside the bone marrow called extramedullary disease or plasmacytoma. So when do we treat? We don't know, but I think we can speculate. Most approved treatment today in relapsed multiple myeloma were based on relapse disease, biochemical relapse disease. But there are some observations to say it's better to treat at biochemical relapse. Some observation came from Mayo Clinic that showed people have done better when they get treated at biochemical relapse. But some people will say, come on, what is the pros and cons of that? Well, 25% of patients who have biochemical relapse, the myeloma protein going up, the free light chain is going up, will have a smoldering course and no progression for 2 years. Maybe, in those group of patients, we jump the gun if we treat early at the cost of drugs, the side effect of drugs. But then pros is that, sometimes when you have a biochemical relapse, it doesn't take a long time to start having symptoms, maybe 5 to 6 months. So I always say in my mind is that if you don't get it right at first relapse, you may not get it right at subsequent relapse. So I think that's also important observation. And what I think one need to know is that with each relapse, the duration of response is getting shorter. And that is not trivial things, and so that's why I think, as you can see here, the duration of response with each relapse is shorter and shorter. So you really don't want patients to be in the 6th relapse because, we tend not to do it right there. We have a shorter relapse and, the outcome is not as good. So I think it's important to get it right early on. So this is something about myeloma. It's called the genomic heterogeneity. So this is really complicated things. But basically what it means is that not all myeloma cells within the patients respond to the same drug in the same way. So there are clones or baby myeloma cells that respond to drug A, but not to drug B. And I think that's a very important observation that I think it was one of Joe's colleague published on that. And so in English, what does clonal heterogeneity mean is that myeloma cells in each patient are a family of odds and aggressive members. And the longer this family stick around, the odder and the more aggressive it becomes. So, family therapy is not going to work here. You can't be politically correct with these nasty cells, and you have to eradicate them early. And because they're all different and they respond to different drugs differently, that makes the case for combination therapy. You're not going to win the battle with one drug. It doesn't work, and there's a lot of evidence to support that. So when I choose a treatment for relapsed patients, I think there are many factors that influence what we do. The disease-related factor, regimen-related factor, and patients-related factors. So what are the disease-related factors? What is the feature of relapse? I mean, it is aggressive, they have kidney failure, they have high calcium, they have bone lesions, they have plasmacytomas, these tumors growing outside the bone marrow. Were they high-risk cytogenetic, high-stage international staging system? So these will influence what we do for these patients. Regimen-related, what was the previous treatment? How did they respond to it? How long did they respond to it? What were the side effects and the toxicity of prior treatment? That would influence what we do next. If you have a drug A that really was horrible for you, I'm not going to use it again, especially if you still have side effects related to it. And I think the depth and duration of previous transplant. If you had a transplant that lasted 5 years, is different than transplant that lasted a year. So we may not repeat another transplant. And I think it's very important, and probably that's the first thing we look at, is patient-related factor. How do they feel? What is their performance status? Are they strong? Are they frail? Do they have diabetes? Do they have neuropathy? Do they have kidney failure? Those influence what we choose. Are they still transplant eligible? What does the patient want? So that should be probably number one. And then obviously, we still fortunate that we can provide most therapy to our patients, but cost and socioeconomics may play a role in what we choose to offer our patients. And you've seen a slide like this, but this is currently available anti-myeloma agents. So I have the rest of the day to talk about each one of those. Not. So we're going to choose some of these things. But they fall into the steroid, the conventional chemotherapy, the immunomodulatory drugs, the proteasome inhibitor. All these drugs, most of them are approved in the management of patients with multiple myeloma. There are other drugs we haven't, they're not yet approved to treat multiple myeloma, but you heard about translocation 1114. There's data to suggest that this drug venetoclax, when you use it with bortezomib or carfilzomib, provide good control of the myeloma. I actually have patients who relapse after CAR T cells, and I've been able to put them in remission with this drug. So there are drugs that are approved, and sometimes, physician will use their clinical judgment based on the biology of your disease and come up with novel combinations. So how does your oncologist decide what to do? It's like you going to this, restaurant that has very long and complicated menu. And believe it or not, it just makes me nervous to look at a menu like that and decide what to do. Well, believe me or not, your oncologist face the same thing. This is what we call, in a way, it's like the Bible for oncologists, called the National Comprehensive Cancer Network sort of guidelines. And look at the therapy for previously treated myeloma patients. And you can see there are a lot of combinations. So it's confusing to the doctor, but I think it's a good news that we have great options, because we can tailor the therapy based on your needs, based on your biology. So that's a good news. So you can use, my colleagues, Mayo Clinic, try to come up with more practical approach, and say, okay, you are on maintenance lenalidomide and you relapse, what should we do for a fit patient? Maybe carfilzomib, pomalidomide, dexamethasone. If you had an indolent relapse or you're frail, maybe we can try daratumumab, bortezomib. So there are, other approach to try to make that menu of options less complicated for the patients. And this is for second relapse. And you can see probably it's a repeat of some of the drug we used in the first relapse. And now we have more options available to the patients. So the first thing I told you is that, myeloma at presentation at relapse is a combination of clones, different baby myeloma cells with different response. And that makes sense that the combination therapy is going to work better than just a single drug or couple of drugs. So this first observation was from study similar to what the Maya study in the newly diagnosed that Dr. Mikhael showed you, but this one is daratumumab or Darzalex with Revlimid dexamethasone versus Revlimid dex in the relapse setting. And the data suggests that actually you're getting longer time without disease-related issues when you use daratumumab compared to just Revlimid dex. So clearly in the relapse setting, I'm not going to use Revlimid dex. I'm going to use maybe this combination because it provides better time for my patients without having to deal with disease-related issues. And it didn't matter when you relapse. Within 12 months or more than 12 months of your initial treatment, you still see benefit if the combination of daratumumab and lenalidomide. So it's an important thing. So there are another monoclonal antibody available called isatuximab, which has been shown in a couple of trials that when you combine it with, for example, pomalidomide dexamethasone is superior to PomDex. And so it is recommended as a combination therapy for relapse disease. And more recently, this drug, monoclonal antibody isatuximab, have been also approved in combination with carfilzomib. So it is another option available to our patients. So again, I am not going to use a single drug. I'm going to use a combinations. And this is another possibility, is the isatuximab with pomalidomide or with carfilzomib. The other thing available to our patient now is these antibodies that are binding to something different. And there are a lot of different sort of approach to these antibodies, because the daratumumab and the isatuximab, these are a naked antibody. What they do is they just bind to the myeloma cells and kind of bring, our army of immune factors to help get rid of the myeloma cells. But there are more ways to enhance these antibodies' activity by, for example, adding a conjugate, adding maybe a toxic agent, something that will make these antibodies, once it sort of bind to the myeloma cells, go inside the myeloma cells and blow it up. Or you can also make it more sensitive by making these antibody able to bring your immune cells next to the myeloma cells and then destroy it. So a lot of option there. So what are some of the novel immunotherapeutic approach? So I have in this table, which is a little complicated, 3 things that 2 of them are approved by the FDA for relapse disease. The one in the middle, the bispecific antibodies, are not yet approved, but I would not be surprised that one of the many that are being tested today will be approved shortly by the FDA. So the first thing is, everybody excited about is the chimeric antigen receptor T cells. So what is that? It's basically a, we take your own immune cells, and those are called the T cells, and we genetically modify them in the factory, in the lab, to become myeloma killer cells. So they will recognize the myeloma and kill it. And so require getting the T cells from you. It's like, apheresis, like collecting the stem cells. You go to the blood bank. You don't need to be stimulated with anything like we do in the stem cells. And then they put you on the machine and they collect these cells and send them to being manufactured. So it has been, amazing. There's one already approved, the Abicma, and then maybe one will be approved this fall. They both showed a great activity. A lot of patients are responding. And actually, some of these response in 1/3 of the patients are complete remissions. The one caveat is that the response duration depends on the product, is about a year. So one would like to see that maybe those responses can be more lasting. However, these were studied in heavily pretreated patients, very difficult to treat myeloma patients. And despite that, we're seeing 75% response rate, a 30% of the patient getting a deep response. So I think once we get a handle of these things, like Joe said, most of these drugs, when they come on the market, they're new. We get to know how to use them better and maybe start using them earlier. With that, then, we can probably improve the outcome with these novel therapy. Problem with CAR T cells, obviously you have to produce the cells. You have to put the patients in the hospital to get them, to get them ready for the cells infusion. And then you have to monitor them carefully for 2 complications. One called cytokine release syndrome. It's like a septic shock. They drop their blood pressure, they drop their oxygen level and things like that. And the other one called neurotoxicity. The patients, have, inability to express themselves or have seizure-like manifestation. Luckily, we are able to manage both conditions in the majority of the patients, and we know how to get the patient through them. But however, it's not a walk in the park. The antibody conjugates, so I'm going to spend more time about them in a minute, are off the shelf. You don't have to take the T cells, send them somewhere, manufacture them, and wait for them to come back. Because while you're waiting, the myeloma is not waiting. the myeloma may cause harm. So you may have to do bridging therapy while you're waiting for the CAR T cells. Now I have a patient in my clinic, they have relapsed myeloma. I need something I can just say, okay, I'm going to give this antibody conjugate. And I think the same thing will happen to the bispecific antibody. They are off the shelf and they'll be easy. And however, we need to be able to make sure that the doctors knows how to recognize the cytokine release syndrome and how to manage it. So what is the major antigen that all these therapies are attacking? Is this called BCMA, or B-cell maturation antigen. It's very interesting protein on the surface of myeloma cells, makes them unique, but also can control the survival of the myeloma cells. And I think that's what makes it a very attractive antigen, very attractive for immunotherapy. So all the CAR T cells, the conjugated antibody, and the bispecific antibody is directed against BCMA. And BCMA is expressed on myeloma cells and their cousins, the normal plasma cells. So we need not to forget that, because I think when we suppress these cells, the normal cells, the immunoglobulin that we produce, the antibodies that helps fight infections, will become very low, and some patients may need to be supplemented with some normal immunoglobulin infusion once a month. So the drug that is on the market approved for myeloma, that is an antibody conjugate, is called belantamab or Blenrep. It's an interesting antibody that has the antibody that binds to the BCMA and then has this conjugate that mefidotin, that when it gets inside the cells, sort of break up the cells and the cells die when it's trying to divide. And obviously the antibody itself will sort of bring on the immune response. So I think you're getting like three different things that help kill the myeloma cells. And as a single agent, about 21 out of 35 patients in the initial trial showed a response. So obviously that single agent activity showing good response. And as I told you, we're not going to win the battle with one drug. So there are a lot of combination being tested that I think is going to be fascinating to see how these drugs will work with other agents. The issue that we have to deal with this drug is the ocular toxicity. So what does that mean? Eye damage. From what? Cornea damage. We don't know why the cornea get damaged, but it does require that we test the patient before we give this drug and start this drug and before each subsequent cycle. And so we have to have an eye doctor that's available to us when we give this drug. And there's a lot of sort of approach to try to figure out what is the best way. Do we really need it every 3 weeks? Maybe we can do it every 6 weeks. So there are trials ongoing to see, by stretching the time between doses, do we make the eye toxicity less common and less severe? And I think the data is ongoing, and my inclination that may actually work. Because I think the antibody by itself, in some patients, the response is lasting a couple of months. So why do we need it every 3 weeks? So we'll see what happens when the data of these trials is completed. There's a new drug that called melflufen that has been tested. It's like melphalan, but it's a little bit more interesting because it has this sort of linker that wouldn't sort of really more release within the myeloma cells, because have that enzyme that breaks it down within the cells. So make it very attractive new drug. And the data again suggests that you're getting a response in a majority of the patient, and some of these responses are reasonable and durable. So that's another drug that is ongoing in clinical trial. So I think, this is my last slide. And basically, I think the best therapy for relapse, that number one is that to recognize that not all relapses are the same. The second thing is that combination therapy does provide better outcomes. So I'm not going to use a single drug. I think all these trials that approved new drugs as a single agent undergoing further studies in combination, and I think combination is going to win. The other great thing is that amazing. I mean, Joe told you, and when we started this business, we said, okay, do we use a single or doublet? And, now we're using triplet, and we're using several different triplets. And maybe in the relapse setting, we'll use 4 drugs, quadruplets. But there are a lot of options, and I think each patient will get the right combination for them. So the optimal therapy is what your disease needs, what your body needs, and we can do it. And the last point, which I really think is very important, and we should not underscore that, is that the best time to get it right is at the first relapse. The good news is that we have options for multiply relapsed patients, but why should we make the patient relapse one more time, or third time, or fourth time? Let's see if we can get more patients at first relapse into complete remission, into minimal residual disease negative state. And I think we can do that. And I think that's my talk. Thank you.
Well, thank you, Rafat. I remember being here at the foundation almost 20 years ago, and they said, go out and talk about the IMF, and they gave me an index card to talk about thalidomide. And I got in front of everyone. There was about 60 people there, and I said, we got great things coming down the road. And I pulled the card out without looking at it before, which I never do that. I don't do that anymore. And thalidomide, and I go, oh my God, what did I just say? So folks, from thalidomide and some other drugs that were in the very beginning, you have so many combinations, and it's critical to get the right doctor, a myeloma specialist. They'll help you through the process considerably more than maybe your GP can. It's just get a specialist. All right, remember, audience Q&A is up. We have about 8 questions. Let's get through some of these questions, and then we'll go on to Tiffany. Rafat, run that talk.
Well, I can help. Direct them if you want, Kelly, just to keep it consistent. So, Rafat, great talk. Love your analogies as well. the menu. I sometimes say that relapsed myeloma is like the Cheesecake Factory menu. I don't know if you've seen it recently, but you need like a table of contents in that thing. There's so many of them. A couple of really good questions here, Rafat, about cilta-cel and just CAR T-cell in general. So maybe I can simplify the questions by saying, do you think we're going to be using CAR T-cell therapy earlier on in the disease course? I know you made a little bit of reference to it, but people are asking, a couple of people are asking about, are we comfortable enough with using more CAR T-cell therapy? I know that right now, unfortunately, there's a bit of a challenge with access to CAR T-cell therapy by virtue of production problem. The same viral vector that we use for vaccines, we use for CAR T, and it's slowing up some of the production. But assuming we get through that part, do you see CAR T moving up earlier in the disease course and getting safer for patients?
Yeah, I really think so. And as you know, there are many clinical trials ongoing looking at your CAR T cells at early relapse, and more importantly, I think there are interest in the high-risk patients using CAR T cells up front, especially for transplant ineligible patients and the like. So I could envision one day that, for example, high-risk patients, they get a good induction treatment, they get the high-dose chemotherapy and stem cell transplant, and consolidate them or maintain them with a CAR T cells. And I think especially when we get a patient to small volume disease or, just a few myeloma cells, you may not need the same number of CAR T cells. And by not giving too many CAR T cells, you may not see the number of cytokine release syndrome and then the neurotoxicity. So I think, this is just the iceberg. I mean, I think we will, see what the clinical trial shows. And once we know that, we can use less CAR T cells, I don't see a reason why it cannot be used. And I think, obviously, all of us in the high-risk patients will not be hesitant to do the clinical trials and show that it's very effective. Obviously, everything we do in medicine, you have to have evidence. And once we have the evidence, I think we can use it. So, but CAR T cells are fascinating. I mean, to see the depth of response with just giving these cells is amazing. So
it really is amazing, isn't it?
For a long time. Yeah.
Yeah, I mean, it's tripling the best single agent drugs we have now in terms of response. And I agree. I think with time, we're going to be seeing it earlier. I think even if we can collect T cells earlier before they've been kind of beaten down with more of the treatment, I think there's a real chance to even be more effective. Tiffany,
also, I'm sorry to interrupt you, but we also now, in the era, we can use sort of donor T cells. Now with these called gene editing, we can get rid of the ability of somebody else's T cells from recognizing our body and causing bad reactions. So we can manufacture T cells from donors, and they will become like an off-the-shelf also CAR T cells. So there are a lot of people interested in that. There are clinical trials ongoing with these donor CAR T cells, and that will be very exciting too.
Oh, can you imagine? Yeah, not having to go through the whole collection and factory production, and there's still challenges. I have a patient this last week where the production was a challenge. We were not able to produce enough CAR Ts, and so it would be really nice to be able to do that. Tiffany, we've got I think a really good question here that I'd love your input on, where someone's asking, what are potential relapse treatments for patients with neuropathy caused by proteasome inhibitors? So how does that kind of alter your thinking about approaching relapse when someone has an existing neuropathy?
Yeah, that's a great question. One of the questions that always comes to mind is, how bad is the neuropathy? Is it, limited to the toes and the fingertips, or is it more extensive and painful? Generally speaking, if we use carfilzomib in a patient with neuropathy, we generally don't see worsening of the neuropathy. But that being said, I always tell my patients, like, if you notice any changes to that, you need to let me know so that we can bring you in sooner. Certainly using monoclonal antibody in combination would be an option. And then potentially using a doublet with an IMiD and steroid, although generally, depending on how bad your relapse is, that also isn't the best, would not be the best treatment. And then there's clinical trials with newer agents that don't appear to have the same degree of causing neuropathy. And then obviously we could also use belantamab mafodotin if it's a patient who's penta-refractory, and then certainly doing a CAR T cell therapy as well. So, I mean, I think there's a lot of different options, and it really goes to how significant is that neuropathy. I would say by and large that, I've been working in myeloma now for 17 years, and the degree of neuropathy that we see now compared to what it was when I first started, it's so much better, because I think, as you'd mentioned before, we've gotten better at knowing how to manage the side effects and the importance of doing appropriate dose reductions as soon as the neuropathy starts, as opposed to waiting till they have like grade 2 or grade 1 with pain. And I think that has really changed things for patients. And then obviously going to sub-Q as well as going to once a week has also helped.
No, that's so helpful, Tiffany. And thank you for commenting about the importance of open, honest communication, because the last thing we want is a patient to be suffering with neuropathy only to find that it's not reversible, because there is a point where you get onto a one-way street and we can't go back and make it better. And I think with this Cheesecake Factory menu, and thanks for whoever said that you can buy the Cheesecake Factory bread at Publix. That was a hilarious comment in the Q&A. But with those menus, we really can choose options that at least have a significantly reduced risk of neuropathy, even in the same class as you mentioned, like carfilzomib and ixazomib. I'll take this question about high-risk smoldering myeloma. I know we haven't spent a lot of time talking about smoldering myeloma. Sometimes I say, again, you put 10 myeloma doctors in a room and you have 12 opinions when it comes to smoldering disease. But this patient says, I was diagnosed in April of 2021 with high-risk smoldering myeloma with an M protein count of 2.7. August M protein count is 3. My hematologist is not talking about treatment yet. Is it too soon, or should I be concerned? Thanks for a great question, Keith. I think There's lots of ways of evaluating this, but I would simplify it as following. It's really important that multiple measures be followed with this. Again, sorry for too many analogies today, but I use this analogy because I like to run every morning here in the desert in Arizona. And if I'm running and I'm heading towards a cliff, hopefully my friend Tiffany will see that I'm about to fall off the cliff and pull me back and not let me fall off. Historically, we defined myeloma by crab criteria, by literally we waited until patients fell off the cliff. Like you had to have a calcium elevation, you had to have kidney damage or anemia or bone disease. When we changed the definition of myeloma, we took some of those patients that used to be called smoldering and put them into active by adding that slim part of the slim crab, where we said, okay, we're going to draw a line 50 feet short of the cliff and say, if you get that close to the cliff, we're going to treat you. We're going to pull you back, as it were. We're going to introduce treatment, because if I see that someone's getting so close to damaging their kidney, do I really want to wait until they have kidney damage? Do I really want to wait until they break a bone? And so the philosophy around smoldering myeloma is changing. We all believe that 50-foot line is probably not the best line. We probably should pull it back a bit more, but we're trying to decide what those are. And so in that space, there's this high-risk smoldering myeloma where people have higher M spikes or maybe higher percentages of plasma cells in the bone marrow or light chains or various features. And there's all these new models being developed. And so, Keith, I'd encourage you to have a conversation with your doctor about that, because it's not just about the M spike. But if the M spike is climbing, that's analogous to me starting to run faster towards the cliff. And so at that point, we do want to intervene, because Rafat said it really well. You don't want to intervene too quickly, because maybe you'll never make it to the cliff and you're just enjoying your run. On the other hand, we don't want to wait until people run into trouble. So I think that's probably the way I would approach that. Rafat, can you comment on the recent FDA warning about melphalan-flufenamide or melflufen?
So I think the warning is really more related to ongoing clinical trial with combination therapy. And I think there's a clinical hold on those trial until further analysis of the side effect that has been noted. To my knowledge, I don't think the drug approval has changed. It's still approved, as an option for a patient who was multiply treated, who has seen, 3 classes of drugs and have 4 relapses or more.
Okay. Yeah, I mean, the actual indication for use of the drug in regular practice hasn't changed. So I'm still treating many of my patients with it, but the clinical trial is being reevaluated. I think according to my schedule, we still have quite a bit of time for Q&A, if I'm not mistaken. Correct me if I'm wrong, Kelly. But it looks like we're up. It looks like we're up to we've got actually time for Q&A on my schedule for another almost 12 minutes. So let's squeeze in some of these ones a bit quickly. We'll go back to this great question of lenalidomide dosing. Tiffany, what's your approach? When do you do 25? When do you go down to 15 or 10? I saw you nodding when I was saying that I do that. And I know there's no perfect study to guide us, but do you have some general principles about dosing of lenalidomide?
Yeah, I think the most important thing is making sure that your oncologist is dose reducing based upon your creatinine clearance. I know we will see patients from outside oncologists where they have an impaired creatinine clearance, their kidney function isn't perfect, and they're at a full dose. So that is going to cause you more side effects if you're not appropriately dosed with how well your kidneys are working. The other thing is we generally will, depending on what the side effect is, if they're having a lot of diarrhea that we cannot manage with cholestyramine or cholesterol, then we'll dose reduce from maybe, if they're at a 25, go to 15. If they're at 15, go down to 10. We usually take patients down by 5 milligram dose levels. And we've had patients who do really well just on 5 milligrams. I think if you're using Revlimid post-transplant, you definitely need to start at 10 milligrams lower if you have an impaired kidney function. Again, making sure that your oncologist is reviewing that and a dose adjusting appropriately. And I think it really goes back to having that open communication with your team, making sure that they're aware of the side effects that you're experiencing, how often that's happening. I usually tell my patients to keep a journal of when you're having your side effects, because there may be something that we can do as providers to kind of help you manage things a little bit better. I've had some patients who, even with stopping their lenalidomide, they still have diarrhea, and then they cut out lactose and their diarrhea improves. So there can be other causes of diarrhea. So you want to make sure that all avenues are being approached rather than just automatically attributing it to the chemo drug, because there can be other things that can happen. I know Beth Feynman had done an abstract several years ago about at Cleveland Clinic looking at those patients who developed diarrhea with Revlimid maintenance and found that those actually were the best responders. But again, it's all about managing your side effects. And oftentimes we can manage it either by dose reducing or adding something to help manage it.
That's so helpful, Tiffany. Thank you. And I got to say that in patients who are maybe older and more frail to begin with, where I'm hesitant to use, like taking them to transplant, often I even just start at the lower dose of 15 milligrams or 10 milligrams, but definitely follow the strategy there.
Yeah, we also do that, like if we have a patient who's really tiny, because most likely like the 25 milligram dose is going to be high, right? My background, I did pediatric oncology for several years. And, it's crazy that like once you get to the age of 18, like, we go to these standard just doses, right? We don't look at, obviously with Velcade and Kyprolis and some of the other drugs we use weight, but generally speaking for our oral agents, we don't use any kind of weight-based dosing, right? And so if we have somebody who's small, then we'll also reduce the dose to like maybe 15 to see how they do. And if they do well, then bump them up to 25. So I think it's important, like what you'd said before, is looking at each patient individually and as their own patient and what their disease is doing, rather than treating all patients the same.
Okay, great. Lots of really good questions come in, so let's try and rapid fire answer. Rafat, what's the latest on 1Q abnormalities? Is that high risk or not?
I think it's still very confusing to me because I have these 1Q patients who are doing great, in remission for a long time, and I have some they don't. So I think that tells you that our current criteria for risk stratification is really very primitive. We just look at the chromosome and say, okay, we have deletion of the long arm of chromosome 17, and that's what would get us in trouble. Actually, the data turn out is actually what's on the other gene, the intact chromosome 17. Is it mutated or not? So I think the more we are doing, DNA sequencing of the initial myeloma cells and single cell RNA, the more we're going to learn what is really the impact of certain abnormality. Just to say that translocation, 1114 or, 414 is bad. Why is it really bad? So what gene is turned on, what genes are turned off? I think that's when we can answer the questions clearly. So I think it, most people consider it, maybe high risk, but I think there's some of this 1Q, they do just fine. We need better.
I think the way I think about it too is, up to 40% of myeloma patients will have extra copies of 1Q. When people have 3 or more copies, it's pretty clear that or 4 or more copies, it's pretty clear that it's a problem. But for those that are just above normal, it's still not clear. Here's another good question that says, I was told that I have to, when I collect my stem cells, they're only good for 1 year. Why is that? In fact, they're good for much longer. We've collected people for 10 years ago and have used their stem cells. So I would have that conversation with your physician to make sure that that's really what they're saying. On the subject of collection, someone said, who can be a donor for CAR T cell therapy with 17p deletion? So I'm not sure exactly they fully understood, but with CAR Ts, right now it's only to yourself. We don't collect T cells from someone else and give them to you yet. We're studying that, but right now that has to be oneself. And similarly, someone asked, "What is
only in the myeloma cells?" Yeah.
Correct. And then someone asked, "What is the best therapy for 17p deletion?" And there's no specific treatment for that, but the way I try to think about it is anyone who has high-risk myeloma, we typically follow, in my estimation, a fourfold plan. Combinations given continuously, seeking the deepest remission possible, with usually the inclusion of a proteasome inhibitor. Combination therapy given continuously, seeking the deepest remission possible, with inclusion of a proteasome inhibitor. I know we could talk about that all day, but I'm just trying to give people some highlights so that they're familiar with it. Here's another good question from Jack. Thank you for your nice comment, by the way, Jack, about the talks. Steroid dosing. Well, that's a whole other discussion that I know Tiffany will make some reference to, but in short, I mentioned earlier the booster rocket analogy that typically, generally speaking, to keep it simple, when people are transplant eligible, we're classically using 40 milligrams of dexamethasone a week, at least initially for the first few months. We may dose reduce them a little bit. If patients are transplant ineligible, many centers will start at half of that at 20. These steroids we love and hate. They boost almost every drug in myeloma. We hate them because they cause insomnia. They cause us to be a little bit on edge. Our partners aren't very happy with us when we're on Dex. It can affect skin. It can affect bones. It can affect blood pressure, blood sugar, a whole series of things. So this is the art of myeloma, where we are really trying to do the best we can for patients with what we have. Another person says, please define courses of treatment regarding describing refractory. Is RVD and transplant one course or four? Rafat, do you want to cover that?
Yeah, I mean, I think right now when you have an induction, transplant, and maintenance, that's considered one line of therapy. Yeah, that's the answer.
That's the simplest way to think about it. Because sometimes the FDA defines therapies or lines of therapy. Line would be, that would all be one. But if you say how many therapies does the person have, then we can say they've had 4 therapies. Tiffany, someone says, with respect to maintenance therapy, are there any alternatives to Revlimid or pomalidomide when those drugs are making neuropathy worse?
Yeah, I mean, the first thing I would ask is if, has somebody tried doing dose reduction with the Revlimid? We generally don't see a lot of neuropathy with Revlimid. That's not saying that we can't see it. But alternatively, we have used Ninlaro on some patients, but again, just monitoring for that neuropathy is really important. And then you could also use carfilzomib. But just really making sure that you're communicating if the neuropathy is getting worse, so that they can adjust things or dose reduce things, because we don't have to stay at that dose level that we started you on. A lot of patients can go down to 5 milligrams or even 2.5 milligrams and do fine for maintenance. So again, I think the importance is really communicating and monitoring how the neuropathy is doing, and kind of really making a mental note of what your neuropathy felt like when you started the therapy, so that you've got something to compare it to.
Fantastic. Well, I think we'll take one more question. I'm sorry we can't get to them all. We do have some Q&A at the end, so maybe we can come back to some of them. But I think this is a great question. I appreciate it, Jeffrey. With all of the studies that are being done on the drug combinations, are studies ultimately being done to find a drug that cures myeloma and not just maintains myeloma? And this really, I think, highlights the overarching principle. You know, the founding mission of the IMF was to find a cure for myeloma. And until we find a cure, to support patients and their families through this myeloma journey. And defining cure in itself is a whole discussion. You know, we don't cure diabetes. We don't cure hypertension, but we control it. I would love to truly cure myeloma. I want to work myself out of a job, frankly. I want to be able to give patients a treatment that would, you know, obliterate their disease where it doesn't recur. And we are taking so many more steps to that. I think what's going to happen is it's not we're going to wake up one day and say, we found this perfect drug and it does it. I think what's going to happen is we're going to start to see a larger and larger fraction of patients going into deep and durable remissions for long periods of time without needing other drugs, or at least needing something very minimal, like maybe a pill or something that doesn't really interfere with their quality of life. And as that fraction grows and grows, as we develop these new therapies, I think CAR T has an opportunity to contribute to that. But please know this is our mission. This is our goal. When patients are getting treatment after treatment, as Rafat described, and side effects, that's not cure. We want to be able to obliterate this disease from the start. And that's why we do all the research that we do. That's why we spend so much time in the lab and trying to understand these cells and really get to appreciating who this enemy is so that we can take it down. So I know that's a generic answer, but that is really what we're seeking to do. So Kelly, I'll turn it back to you because I know we're almost ready for Tiffany's talk, but I'll turn it back to you, boss. Thank you for letting us answer all these questions.
Oh my God, that was a vigorous chat session there. Listen, folks, fill out that clipboard there about what just happened. That is what happens at regional community workshops. Questions are answered, and the doctors get to go back and forth and give you straight up information about your disease. Well, the third person that's coming up here is Tiffany Richards. She, as she said, has been involved with it for 17 years, and I've been involved with it for about that much time, and we've known each other about that much time. And she's a wonderful, wonderful nurse. She is on our Nurse Leadership Board, which celebrates 15 years in operation. There's no other board like that at other foundations. So Tiffany, 15 years. And that's another example what the IMF offers. We really care about the patient. I mean, the patient, if you drew a circle, the patient is in the center of what we do. Everything that we do, it is for you. There's no other foundation doing that or anything like we do it. And, we have an info line. We have our website at myeloma.org, which you'll be able to get more information about this regional community workshop. But it's all there for you to help you be educated and help you interact with your doctor. These will help take steps away and get you moving faster on your journey. So with that being said, Tiffany, take it away.
Thank you. So we're going to just talk about how to be the commander of your galactic journey. So we're going into space now. So all members of you need all crew members to have a successful myeloma journey, right? So here's you and your caregiver, and then you have all these people that are on the outside helping you to navigate the journey. So you're going to have your general oncologist, and then you may also have a myeloma specialist. You have your primary care doctor who's going to be helping you to manage any other problems that may come up, and like doing cancer screenings, evaluating for high blood pressure, diabetes, heart disease, things like that. Then you have your family and support network. You have allied health staff such as physical therapy or occupational therapy. And then you also have potentially your cardiologist or lung doctor. And so it's really important that you understand the different roles of each member of your healthcare team. And what I always tell the patients, it's important to have your primary care doctor because they're staying up to date on how to manage your blood pressure, how to manage cholesterol, things like that. I graduated 17 years ago, so a lot has changed in the management of hypertension and hyper elevated cholesterol levels since that time. So it's important that you still keep that primary care doctor in the midst of your team. We're just going to talk about how to prepare for appointments in the COVID era. So one thing is that you want to make sure that you're writing down your questions and concerns, including those questions about COVID. Make sure that you bring a current medication list, and this is really, really important. It's also important to carry that medication list with you. Now with smartphones, it's very easy to keep an updated list. Any medical or life changes since your last visit, and then current symptoms and if they've changed at all. It's important that you wear your mask. Ask your most important questions first. understand your treatment plan at the end of the visit and what are going to be the next steps. And then make sure that you know who to contact and when. And it's also really helpful to include a caregiver for another set of ears. I usually will tell, like, if I'm meeting with a patient and a caregiver, somebody just needs to be listening, and then the other person can be taking notes. And so that way, you've got that backup. And then back home, making sure that you're taking precautions to stay healthy and to stay safe. So at this point in time, because we don't really know what kind of immune response patients are having from the COVID vaccine, we don't know yet, like, at what level confers immunity to COVID. And so it's really important that you're still taking COVID precautions, making sure that you're wearing your mask when you go out, and not taking it for granted that you've been vaccinated so that you're safe. You want to make sure that you communicate with other members of your healthcare team, take your medications as directed, and then follow up with members of your healthcare crew. You could consider telemedicine visits. I know we have really, since COVID started, have gone to having more telemedicine visits. And right now in Texas, our cases are ridiculous. And so we're back to doing a lot more telemedicine visits. And so you want to make sure that, you know how to make an appointment, when to do your labs. Are you going to need a script? For our patients who live outside of Houston, we often send them a script for them to get labs done locally. Make sure that you know what type of technology to use, because every telemedicine visit might be different with each center. Plan your location, making sure that you've got a good Wi-Fi, that it's quiet, and that it's a well-lit location, and that you're not driving, because I've literally had patients who are driving when they come into the visit, and then I'm like, okay, we can't do a visit with you driving. So don't be driving if you've got a telemedicine visit coming up. Making sure that, if possible, like, collect recent vital signs. You could easily measure your heart rate and your temperature, and then you can get, there's a lot of self-serve blood pressure cuffs at many pharmacies now. And then at the end of the visit, make sure you understand what type of appointment it's going to be. Generally, what we're doing now is doing virtual for about 2 to 3 months, and then going to in-person, although we have a surge right now. And so we're keeping patients as virtual as much as we can. And then also make sure that you've told your team what medication refills that you're going to need. As far as how to prevent infection, remember that the immune dysfunction comes from myeloma, but also from the treatment. Making sure that you're doing good personal hygiene, good hand washing, avoiding crowds, avoiding sick people, that you may need growth factor support potentially if your absolute neutrophil count goes too low. Making sure that you're up to date on your immunizations, but you cannot have live vaccines because that can place you at risk for actually getting the infection. And then, flu season is coming upon us. And so again, making sure that you're getting that flu shot. I think it becomes available. My parents were at the pharmacy yesterday asking, and it'll be available September 1st at most pharmacies. Making sure if you need to be on any antibacterial for infection prevention. And then it's really important that you're on antiviral. Almost, the majority of our treatments, whether that be the proteasome inhibitors or monoclonal antibodies, can place you at risk for getting shingles. So you want to make sure that you're either on valcyclovir or acyclovir for that. And then making sure you know what to do if you get a fever. So generally we have our patients go if they have a temperature greater than 100.4. But if you develop shaking chills, you should really come into the emergency room. And I don't mean like you're just feeling cold. I mean like where you are so cold that you're literally shaking. You should come into the ER even if you don't have a fever. If you're having shortness of breath, if you have chest pain, if you're low blood pressure, if your blood pressure is dropped, you want to make sure that you go to your local ER. Infection can be serious for myeloma patients because, again, you aren't going to have the immune system to help you fight off those infections. So myeloma, as well as the treatments that we give you, contribute to how you're feeling, right? So myeloma cells can cause a lot of symptoms, right? So it can cause fatigue. It's going to place you at risk for infection. It can affect your kidney function. It can increase your calcium level. It can cause your hemoglobin to drop. And then it also can cause bone pain because those myeloma cells are destroying the bone. But then we also have the treatments, right? And so the treatments kill the myeloma cells, but they also can affect our normal cells, right? So we can see a decrease in the hemoglobin that way, which can cause fatigue. The treatments themselves can cause fatigue. Some of you have already talked about peripheral neuropathy, can cause diarrhea or constipation. Some of the treatments can place you at risk for getting a blood clot. The medications themselves can place you at risk for infection. Some of our drugs one of our drugs can cause eye problems. And so all of those things together really contribute to how you're feeling while you're on therapy. So what can happen if symptoms are not being managed effectively, right? So if your symptoms aren't being addressed, you can get depression. It could contribute to anxiety because if you're nervous, if you don't want to go out to eat or go see people because you have diarrhea, then you're going to be like anxious to go anywhere, right? It can lead to social isolation, although I think like all of us are having social isolation right now over the last year and a half. But certainly symptoms that are not being managed can lead to that further. It can lead to missed doses. You may start skipping treatments, which then leads to a reduced efficacy, how well the drugs work. And then obviously it's going to reduce your quality of life. And so it's really, really important that you're communicating to your team, like what symptoms you're having, how often you're having them, and when you're having them. I had mentioned before about keeping a symptom diary. It can be really, really helpful. So sometimes we have patients who are on a Velcade regimen and they get diarrhea the day of and the day after. And so then I can tell them to take some Imodium the day of the Velcade, and then that may reduce the diarrhea that they're experiencing. Many options, but your team cannot help if we don't know about it, if you're not telling us. And so it's really, really important, particularly when it comes to neuropathy symptoms. I generally tell my patients, I don't give a list of descriptors. I have them, say, how do you know, what do your hands and feel like now? And they oftentimes, especially if they're newly diagnosed, are like looking at me crazy. Like, what do you mean? How do my hands and feet feel? I don't really notice them. Well, if you start to notice your hands and feet more, then that could be signifying that you're developing neuropathy. And then also make sure that you express your priorities, right? So fatigue is often a concern, but if the fatigue is really bad, then it may be like, okay, I want to reduce the treatment, the doses, but for some people, they're like, well, it's an inconvenience, but overall I'm doing okay. And so make sure that you kind of express what your priorities are as far as managing your symptoms. So steroid side effects. So, as Dr. Mikhael had said, like steroids help kill the myeloma cells. They are great at killing myeloma cells, but they have their own set of side effects, right? So we can see irritability, mood swings, depression. We can see difficulty sleeping. You kind of, when you're on the steroids, you're kind of all revved up. And then when you come off of them, you have this horrible fatigue and just want to sleep all day. It can place you at risk for infections. It can cause muscle weakness, particularly to the thighs and the upper arms. It can increase your blood pressure and your blood sugar levels, leading to steroid-induced diabetes. It can cause weight gain. It can cause skin rashes. It can cause bloating, hiccups. It can cause heartburn and ulcers. It can cause gas. It can cause facial flushing, blurred vision, and cataracts, right? So it has a lot of side effects with it. And so we need to help you to be able to manage those side effects. So one of the things for insomnia, what I tell patients when I'm starting them on a steroid is to first take it in the morning, 30 minutes after breakfast, and then kind of look at how long it takes for you to start to feel the steroids kick in. And if it's more than 4 or 5 hours, then I would try taking the steroid dose at night, but you need to take it with food because you may get 4 or 5 hours of sleep that way so that you're not staying up all night. You want to make sure, again, like I said, take with food, make sure that you're on medications to prevent shingles, and then you may need to be on some over-the-counter prescription medication. So I usually start patients on Pepcid, and I tell them to get Gas-X over the counter in case they get bloating. So what about fatigue, depression, and anxiety? So I would say that it is normal when a person first gets diagnosed with cancer to be depressed and to be anxious. That is a normal human response to getting cancer. And these all can affect your quality of life, and it can affect your relationships. And it can be to, anemia. It could be due to pain. It could be due to you're not as active as you were. You've had to adjust what activities that you are able to do. But also it can be from just having your bone marrow be suppressed. So how can we manage? So one of the things that we can do to manage fatigue is actually exercise. There's been several studies that have been done in cancer patients who are on treatment that show that exercise actually helps to improve fatigue. And it seems counterintuitive because you're tired and you don't feel like getting up, but if you go for a walk, you're going to feel better. I know I myself, I hate exercising, but if I exercise in the morning, I'm a much pleasurable patient. We can making sure you're getting proper rest, making sure that you have a good support system. And it may just be that you need to see somebody for some counseling, and that's okay. Sometimes it's actually really helpful to have like an outside person that has no like emotional connection to you to be able to talk and just get out whatever it is that you're feeling. Transfusions might be indicated, dose reducing medications, or if you're having depression and anxiety, going on an antidepressant can be helpful. And what I like to tell my patients is that we are giving you medications that can affect your brain chemistry. And just like those medications can affect your pancreas and cause your pancreas not to work well, the same thing can happen with the brain. And you would not take insulin if your pancreas wasn't working right, right? So the same thing should be for our brain. Our brain is no different than our pancreas, our liver, our heart. And sometimes we just need to address that. Myeloma cells can also lead to bone damage. Approximately 85% of myeloma patients develop bone disease. You want to make sure that you're doing some sort of weight-bearing activity, but you don't need a lot of weights. 5 to 10 pounds is all you need. Making sure that you're on vitamin D, talking to your doctor if you need to be on calcium. They will likely have you on bone strengthening agents, either Zometa, Iridia, or Xgeva. And then making sure that you report any new pain to your healthcare provider and let them figure out if you need to have some imaging done. So management of pain and how can we prevent it and how can we manage it? Well, we can prevent pain by treating the disease appropriately. Use bone strengtheners to decrease the fracture risk, and antiviral to prevent shingles. You may need some sedation before procedures. We generally set our patients up with pain management because they can do a variety of procedures to help patients with their pain. And then you can also use alternative medicines. Acupuncture, we found at our center, can be helpful for neuropathy at times. And so making sure that your pain is being addressed. And sometimes we do have to do some radiation therapy for that. Peripheral neuropathy. So peripheral neuropathy occurs when there's damage to the nerves and the extremities, and it can be anything from numbness, tingling, prickling sensation, sensitivity to touch, burning, pain, or cold sensation. Again, like I said, I don't usually tell people exactly what it's going to feel like because everybody experiences it differently. I've had patients tell me they feel like they're on hot coals or walking on rocks. ways to prevent it is to use Velcade once weekly, as well as give it as a subcutaneous injection. We actually don't do any IV Velcade anymore at our center. You can use massage. Vitamin B complex can be helpful. Making sure that if you do have neuropathy, that it's a safe environment. So get rid of throw rugs, making sure that you're wearing shoes at all times, and just making sure that your environment is safe. If your peripheral neuropathy worsens, then we may need to change your treatment or lower the dose. And then if you're having balancing problems, we can use physical therapy or occupational therapy. And then sometimes we have to use oral or topical pain medicine. And for the oral medications, we usually use either gabapentin or pregabalin or Cymbalta to help with that. And so those are all things that we can do to help you manage the pain that you experience from peripheral neuropathy. But again, the biggest thing with all of these symptoms is communicating to your team. If we don't know, we can't help you. And oftentimes particularly with neuropathy, patients will be like, no, I'm doing fine. Then when I go to examine them and I touch their legs, they about jump off the table. And I'm like, wait, I didn't think we had any problems. And so we do have ways of finding out if you are having symptoms, even if you don't want to tell us. One of my cues for weakness is to get you up on the exam table and see how you do with stepping up onto this step. And if you can't step up there and you were before, then I know we need to do something about the steroids, even if you're saying I'm fine, because you're not fine. So we have ways of knowing these things. So just communicate to us. And so the IMF has lots of resources to help you. You can go to their website and you can find videos. You can find the IMF teleconferences. They have tons and tons of brochures and educational material that you can find about each type of treatment, about how to better adhere to your medication regimen. And so you have lots of resources out there. And so I'm happy to take any questions in this next section.
Tiffany, yay! That was a great presentation. Today's been great, guys. I want to reiterate the fact that we do have everything you need for myeloma, period. You just go to myeloma.org, or you can call for our hotline at 800-452-2873, our info line, excuse me, and they'll help you with anything you need to know. I've already beaten this dead horse, but I'll do it again. Please fill out the survey. We have we have a lot of questions, so I'm going to defer to Dr. Joe right now to moderate.
Great. Well, thanks, Kelly. And thanks, Tiffany. Yeah, a whirlwind of information, but yet still presented in such a clear way. I just really enjoy listening to you, Tiffany. You are such an expert in myeloma on every realm, in particular in what you describe in supportive care. So it's just, as a lot of the notes are coming in the Q&A, great presentation, fantastic. So really appreciate that. So lots of questions. I'll come to the COVID questions in just a minute, but let's talk a little bit about this. There have been a lot of questions about dexamethasone, Tiffany. So this one is, my side effect is diabetes as a result of Dex. There's no history of diabetes in my family. Dex also results in some orthostatic hypotension that affects my quality of life. What can you say to this patient, Tiffany?
Yeah, so we can see steroid-induced diabetes, as well as making patients who already have known diabetes, making their sugars worse. We try to work with our endocrinologists to help to manage that, but sometimes we do have to reduce the dose of the steroids if the blood sugars are getting too high. As far as the orthostatic hypotension, one of the things that would come to mind anytime a myeloma patient has orthostatic hypotension is potential amyloid, and making sure that that's not the cause of the orthostatic hypotension. But probably talking to your oncologist. We work with our cardiologists, and a lot of times we have to put them on Florinef to help manage that. But definitely, whenever I hear, somebody say orthostatic hypotension and they have myeloma, my first thought is amyloidosis and making sure that that's not the issue.
Really helpful. Absolutely. Yeah. Although we focused so much of our discussion on myeloma, it's so important not to forget about the potential of amyloid. It's a whole other discussion. Well, just while we're on this, Tiffany, there was another question about neuropathy. I've been on Cytoxan, Dex, and Velcade for 13 years.
Oh, wow.
My time between each treatment has been extended to 5 weeks until this past March when I was given a vacation. Can I expect my neuropathy to improve, or have I just been on treatment too long?
So if your treatment was held in March and it hasn't gotten any better, then it's likely not to get better than where it is now. Unfortunately, you should have seen improvement at this point. So yeah, unfortunately, I have to be the bearer of that bad news. But I would definitely talk to your your team about, are there any medications that you could be taking to help with that? And then, if your blood counts are fine, to maybe look at doing acupuncture to help with that. We did a study at our center looking at acupuncture in patients who had peripheral neuropathy from treatment, and we did see some improvement. So you might want to consider, checking that out.
Yeah, no, that's a great suggestion. I've actually had a number of patients who've really benefited from that, but it's so hard because, as we said before, right, we're in that kind of rock and hard place. Like, you want to control the disease, but you don't want to put someone at greater risk. And unfortunately, that can be a one-way street, as we've described. So, Rafat, I think we can all help answer these questions, but let's think a little bit about COVID, and in particular, the booster shot. So someone asks, what is the recommended best timing in between myeloma treatment for getting the COVID vaccine booster shot while on treatment? I am currently on monthly Darzalex Faspro treatment. And I think there have been a couple of people that have been asking this. Another person said, I'm planning to get a COVID vaccine booster right after my 21st day of treatment before my 7-day break. Is that a good plan? And so, Rafat, I'll let you answer that with maybe just starting that. As I sometimes have said, we have more COVID experts than COVID patients in the country, meaning everybody thinks they know, and in fact, most of us don't know very much. And it's because we're learning. I mean, we can't expect to know all these things. But in your opinion, at least, Rafat, how would you approach this situation with respect to the timing now that our patients, and actually many of us, I understand that you've had yours, and I know I'm scheduled next week to have my booster shot. What would you tell your patients about the timing of that shot?
Come on, Joe. I'm the Fauci of COVID disease. I know everything about it.
Oh, I love it. I love it.
Yeah, you know what they call the boosters,
yeah, we've said Dr. Dury. We've said Dr. Dury sometimes because he's been doing so much with COVID. He's the Sanjay Gupta of COVID and myeloma, but I'll call you the Fauci. That's fine. That's good for me.
Yeah. I think if you look genetically, I'm so far away from Fauci, and same thing with Brian is so far away from Sanjay. No, the truth is, obviously, we are learning, as we go. Everybody's, having an observation about, the perfect timing of the vaccine. And I think personally, I like the idea that you're going to get the vaccine 3 weeks after Faspro, daratumumab. My recommendation is that don't get the Faspro, the next month after the vaccine. I think you want the vaccine to work. My experience suggests if you are on daratumumab monthly, you're going to maintain the immune response like anybody else. If you're getting anti-CD38, Faspro, cetuximab, or BCMA therapy, you may not maintain the immune response, and you need to be checked for that and get your booster vaccination. But try to allow the vaccine to work. Don't get the anti-CD38, the Faspro or the daratumumab the month after the vaccine. Obviously, everything we do in medicine is risk and benefit. If you have really ugly myeloma and you need to be treated for your myeloma, get treated and use your social distancing and other things to prevent you from getting COVID. But if you have the luxury of waiting a month to get your second shot of Faspro or infusion of daratumumab, I think I would wait.
Yeah, I mean, I think it's so hard to know, right? It's so hard to be concrete in everything and anything in this. One thing we do know is, please, dear God, get the vaccine. Right? That's, I mean, I shared with the team before we started. Sadly, right now, we have 250 patients in my hospital alone admitted with COVID. That was a few days ago. It may even be higher by now, sadly. And we are consistently seeing 96 to 97% of them are not vaccinated, which is tragic. Even our cancer patients and our myeloma patients are conferring significant benefits from the vaccine. So yes, we want to try and optimize the timing, but if you don't have that chance to optimize timing, get it, because I think it's so important. I'll answer this question. If kappa light chains are very high, but M spike is only 0.6 and disqualifies me from a clinical trial, is it proper to go off current Revlimid and Darzalex and Dex and wait for an increase in M spike? That's a tricky question, Darlene, and I think it's important to have that discussion with your physician. We know that sometimes we have to jump through a few hoops to make people so-called eligible for transplant for trials, although I know that more and more trials are including just light chain measurements. So hopefully many of our trials now allow people with just light chain disease to go on that measure alone without the M spike. But we want to be careful that we don't put you at greater risk by taking you off treatment for sake of it. So that's a tough question to answer in a workshop like this, but one that we would encourage you to look into a little bit more. Tiffany, someone asks, could Tiffany speak to the use of medical marijuana for pain management?
So I don't have much experience with that. Medical marijuana is not legal here in the state of Texas. So, and I don't really have any data to be really able to provide you with any recommendations. I don't know, in California, I believe it's legal. Dr. Mikhael, so maybe you've had some experience, but at this point,
you need personal experience?
In the state of Texas.
Well, not personal experience, to be clear, but I do have experience.
Not personal, I meant like patient-wise.
So I live in Arizona and practice in Arizona, and we do have access to it. And frankly, 15 years ago, before I left Canada, when I was in Canada, we used medical marijuana. So there's no perfect answer to it. You know, I look at it as one tool in the toolbox. And as the nurse practitioner I work with, Susie, who's just absolutely remarkable, often says to our patients, when it comes to pain management and sometimes even neuropathy management, and I'm sure you know as well, Tiffany, sometimes, frankly, it's trial and error. I mean, I can't always predict who's going to do really well with one drug versus another. Some people really do well with opiates. Some people don't do well with morphine or something like that. And others may do well with different agents. So we have lots of different choices. And medical marijuana is one of them. Obviously, if it's legal in your state and it's prescribed, all I tell patients is that this, I don't personally prescribe it. We have it go through our pain management service, so that they're much more expert. You know, this is not the place to, this is not the drug you want to get from your cousin Vinny, as it were, right? I mean, this has to be done. I'm not trying to make too much light of it because it can really be helpful to patients, but I would follow the legitimate channels that are needed because it can be very helpful. I have some patients in whom it's really helped them, and I know that it's been of value to them. So I don't dismiss it, but I also want to put it in its right context because there are those who make it sound, of course, like, you know, cannabinoid products are going to save the planet. So that's not really really that appropriate. Rafat, we have a question here, and I know it's an area of tremendous challenge. I just gave virtually a lecture late last night to Australia on this topic, but I'd be interested in your view. Is what are we doing these days for plasma cell leukemia? What is the latest thinking on how we approach this, if you will, most aggressive form of multiple myeloma, where the plasma cells have not just been growing in the bone marrow, they've spilled out into the peripheral blood and can cause a lot of grief that way?
Yeah. I just want to mention to Tiffany that I feel sorry for her. You know, all these great things in medicine, like medical marijuana and masks are illegal in Texas. So maybe she needs to move to California.
Well, there's some change in law that's coming on September 1st, but I don't know. I don't understand it because it's not like just clear cut, right? We don't do anything clear cut in the state of Texas. It's always all these caveats.
Right. I'm trying to avoid to answer the questions about plasma cell leukemia because I think it's really a hard one. So I think the question is, so you have plasma cell leukemia that sort of the first presentation of the disease, and then you have a plasma cell leukemia that happened at relapse. And I think both of them are really bad, but I think obviously if you are at presentation have a plasma cell leukemia, I would say the best approach is really the most aggressive combination. You use your quadruplet to try to get the disease under control, and you treat them like any other high-risk disease. You want to continue therapy. You want to use a maintenance therapy that include the proteasome inhibitor like bortezomib or carfilzomib. In the relapse setting, obviously, that's a challenge, and we all trying to figure out the best approach. My approach to the relapse setting when you have a plasma cell leukemia is to consider the combination of aggressive 4-drug regimen, such as, VD PACE or DPACE, 4 days of chemotherapy in the hospital, couple cycles to try to control the disease. I think it's an area that is challenging and does require aggressive induction, aggressive management, and continuous therapy to maintain the response.
Yeah, I think you captured it really well. I'm sorry?
I don't know what you said to the Australian last night about.
Oh, well, we've just been doing some more work in this, published a couple of papers in the last few months, but you've summarized it well. You just have to be very aggressive. I think we're redefining plasma cell leukemia. You used to have to say you need this certain quantity of plasma cells in the peripheral blood, but we're showing any plasma cells in the peripheral blood confer a more aggressive disease and therefore have to be treated more aggressively. So there's no perfect plasma cell leukemia a cocktail, as it were. And I know for those asking, is there a certain trial or center? We've tried to do this. It's just really hard because it's not that common. So you'd need so many different centers involved in a clinical trial, and it's made it, a little bit difficult. But the principle I said earlier of combination continuous with deep response, including a proteasome inhibitor, is likely similarly what we're going to be doing for this. Right. So Tiffany, we had another question that came in here that made me think of you when someone was asking about their dexamethasone. Sorry, I just lost my. Yeah, here it is. I am new in relapsed myeloma. I was taking 10 milligrams of Revlimid. I suffer with diarrhea and severe dry skin. My dry skin problem started a year ago before myeloma, and the Revlimid has made it worse. They also mentioned they have some spine issues. What questions should I be asking my doctor?
One of the things, so for the diarrhea, we can use, there are 2 medications that you can use to help potentially with the diarrhea from Revlimid, and that's Questrin or Colestipol, that can be very beneficial for managing the Revlimid-induced diarrhea. So I would definitely ask your oncologist about starting on that. For the dry skin, I don't know what kind of lotion you're using. We know that the IMiDs can cause dry skin, although it's more problematic. We see it more with thalidomide than we do with Revlimid, but it can. Make sure that you're using a lotion that doesn't have alcohol in it, because alcohol can also dry out your skin. So really look at the ingredients of your lotions to make sure that they don't have alcohol in it, because they put alcohol in it so that the lotion dries faster. But we don't want your skin to dry faster. We just want it to get absorbed. Then using lubricants that have like shea butter or potentially like coconut butter. Those things can be really, really helpful. So I would try using that.
Great. And let me just also say, it's so nice. Many of you in the question and answers haven't just been asking questions, but have been making very nice comments and have been very encouraging. one individual said this was their first workshop, Kelly, and they've really, really enjoyed it. So it's very, very helpful, very, very helpful to us. Rafat, here's a question. What kinds of things can a patient who is just at the start of possible myeloma do to slow the progression? Say when there's an elevated IgG and kappa light chain, but nothing else significant. Is there something we can do to slow progression, I guess is the question.
That's a tough question. I mean, I think there's ongoing research trying to figure out, how we, what are the things that lead to the progression from smoldering myeloma to full-blown myeloma, or from monoclonal gammopathy, if indeterminate significant, to myeloma. I don't know if our colleague, Irene Gabriel, is doing the big study called the PROMISE study to look at family members with, pre-myeloma condition and see factors that influence that. I don't want to sort of tell you that this is always the case, but there's a study that was published from St. Louis VA group that showed that people who have multiple myeloma, if they were smoldering or have pre-myeloma condition like MUGUS, and they were obese, they have 4.5 times chance of developing multiple myeloma. So maybe weight loss could be a way to, prevent the progression to multiple myeloma. But I really think it's multi-factors, and we still don't know. But for example, I think if you really have a pre-myeloma condition, be the healthiest you are. You're not going to lose anything. You probably reduce your risk of diabetes and heart disease. And when, God forbid, you develop myeloma, you will tolerate the treatment better. So I think, the healthier you can be, the better for you. So do it, do the exercise, do the weight reductions, control your blood pressure. You're going to feel great in general, and you may, delay the progression to myeloma. And when you have the myeloma, you will deal with the side effect of the treatment better.
That's so well said, Rafat. And I really, really appreciate what you said. It's absolutely true, isn't it? I mean, we don't really know the cause of myeloma in 99% of the cases. We don't really know. But we do know is when we can keep people as healthy as possible, not only will it facilitate their treatment, it'll facilitate their general health and their well-being through it. I think the only modifiable risk factor we can think of really is weight, as you said, because we know it is associated with significant obesity. So I think you've answered that really, really well. Now, time is just about gone, so I'm going to go back to you in just a second, Kelly. I got one last question that I'm going to answer, which is it okay to take dexamethasone at night before you go to bed? And Tiffany, I'll get your input on this. I'm just going to quickly note that in our experience, and I looked at a larger cohort of this when I was at Mayo Clinic, was we found that actually about 1 in 4 or 1 in 5 patients, when I asked them about their feelings after taking dexamethasone, when did they start to feel a little bit edgy? When did they feel that boost of energy? Majority of people, it happens within the first few hours, but there are some, maybe 1 in 4, 1 in 5, where it doesn't really kick in for another 8 or 12 hours. And I have some of those patients actually take their dex at night, because then they can sleep through the night and they get that burst of energy the next morning. And so it really depends on some circumstance. I don't know, Tiffany, has that been your experience as well?
Yeah, I would say that the majority of them, it kicks in pretty quickly. And so when I first start somebody on dex, I always tell them, kind of pay attention to how long, because they know, when it kicks in, they can feel it, right? And if it, is 5 or more hours, I tell them to take it at night. Because even if they get 4 hours of sleep, that's better than no hours of sleep. Just make sure that you take it with food. You don't want to take it on an empty stomach, because that will, cause you some distress and heartburn and ulcers and things like that. But yeah.
Great. Well, thank you for answering all these questions. I don't know, we had, Kelly, 60 questions or 56, 57 questions. So it's been pretty impressive. So I'll turn it back to you, boss, to wrap us up and close off, because we are on time.
We are. And gosh, people, thanks for all the questions. It was remarkable. It's the best question session I've had this year. So there's a few people I could thank on there that I know personally, but we keep it all private. So thanks, everyone, for doing that. These slides are going to be provided later on through an email that will help you out going through some of the scientific stuff, although I will say that the doctors really were clear about the scientific slides. The next slide, please. There it is, my famous clipboard. Please fill it out. I'd love to see your responses. Seen some good responses in the questions, so I'm incredibly grateful. And again, I want to thank our sponsors dearly. It's the Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, and Takeda. That's it for today. Thank you, Dr. Rafat. I call you by your first names. Dr. Abenar, Dr. Mikhael, and Tiffany for doing this presentation on Saturday. Joe, go run. Rafat, do whatever you do. And Tiffany, feed your cat. It's sitting in the back window.
I know, right?
Thanks so much, everybody. Such a joy to share the stage with these amazing people.
Bye, guys. Roll it.